Med History.
Brain-eating amoeba, when water enters the nose. In 2022, fatal brain-eating amoebic infections were registered in states where waterborne pathogens had not previously been encountered. Also this year, at least 3 people have died from brain-eating infections. The amoeba has already been found in lakes and rivers in Iowa, Nebraska, and Arizona. So at the end of October, the Medical District of Southern Nevada issued a statement on the death of a resident of Clark County under the age of 18. A brain-eating amoeba has caused a fatal infection. Fowler's Naegleria is a species of unicellular eukaryotic organisms from the family Valcomyphidae. Representatives live in natural and artificial freshwater reservoirs at a temperature of 25 to 30 degrees C. A facultative human parasite that causes primary amoebic meningoencephalitis, which affects the nervous system and, if left untreated, leads to death. The main route of infection is through the nasal passages and the olfactory epithelium, from where the parasite enters the olfactory nerve and through it into the brain, where it spreads through all its departments. Another possible route of infection is by inhalation of aerosols if they contain parasite cysts. Naegleria fowleri is commonly found in bodies of warm, fresh water, such as lakes and rivers, and in geothermal waters, such as hot springs. How does an amoeba cause disease? Amoebas cannot reproduce by division while they are in flagellar form. However, if they lose their whip, they may split up. The amoeba infects people by entering the body through the nose and then into the brain. It is not dangerous if swallowed by water and is not transmitted from person to person. Amoebas entering the olfactory canal pass through the nasal mucosa and settle in the cerebrospinal fluid and brain. They cause meningitis, an infectious inflammation of the meninges of the brain and spinal cord, accompanied by intoxication and fever. Patients also have symptoms of rhinitis, nausea, headache, and eye pain. After a short time, loss of consciousness, coma, and death occur. The disease was first reported in 1962 in Australia. The causative agent of Naegleria fowleri infection is named after Australian scientist Malcolm Fowler, who presented a report on a previously unknown pathology. The infection is widespread everywhere, but it is more common in countries with tropical and subtropical climates, which is associated with the peculiarities of the development of pathogenic amoebas. During the period from 1962 to 2017, 143 cases of non-glariosis were registered in the United States, of which only 4 ended in recovery. In other cases, there was a fatal outcome. Seasonality is characteristic. The incidence rates increase from July to September, which is explained by the temperature regime of the existence of non-colonies. Young people and children who actively swim in lakes and pools are more often affected. Scientists cannot yet explain why only up to 8 people per year out of millions of swimmers get sick. Symptoms of non-glariosis. The incubation period is 2-3 days, less often up to 2 weeks. The disease belongs to the category of rapidly progressive. A detailed clinical picture is formed within about 5 days. Patients usually die on 1-18 days. The initial symptoms are not strictly specific. The appearance of signs of general intoxication is characteristic. Weakness, lethargy, drowsiness, headaches. There is a pronounced feverish reaction. Dyspeptic symptoms develop, nausea, vomiting. During the peak period, there is an increase in manifestations indicating the involvement of the central nervous system in the pathological process. There is rigidity of the occipital muscles, general meningeal symptoms, signs of damage to the cranial nerves, especially olfactory, decreased or loss of sense of smell, hallucinations, convulsions. Neurological deficits are increasing up to coma. There is no data on the development of the immune response and the preservation of the immune status relative to non-glariosis. Complications. Non-glariosis is a fatal disease. The diagnosis is most often made posthumously after examining the biopsy material. Patients die from edema of the brain and dislocation of its trunk, multiple hemorrhages with destruction of the brain substance. In addition, the cause of death may be the formation of pulmonary edema and the development of acute respiratory failure. During autopsy, signs of myocarditis and pneumonia are often detected, but there are no lifetime symptoms of these pathologies, and microscopy does not detect parasites in the lungs and heart. It is believed that in people with immunodeficiency, the generalization of the process with the appearance of multiple organ lesions of a specific etiology is possible. Diagnostics. The diagnosis of non-gliriosis is associated with significant difficulties due to the non-specific nature of the symptoms, the speed of development, and the rarity of the disease. The examination is carried out by an infectious disease specialist. Upon examination, positive meningeal signs and signs of cranial nerve damage are determined. With the development of meningoencephalitis, focal neurological symptoms are revealed. Differential diagnosis is performed with meningitis and meningoencephalitis of bacterial and viral etiology. The following clinical and laboratory methods are used in the diagnostic process. Detection of the pathogen. Many trophozoites are visualized in cerebrospinal fluid or brain biopsies under microscopy. Neutrophilic leukocytosis in the cerebrospinal fluid is characteristic. It is possible to use the cultural method by sowing the substrate on a nutrient medium, however, due to the considerable duration of the study, its practical significance is low. Identification of infectious markers. Currently, serological methods are actively used in the diagnostic search process to identify specific antigens using immunofluorescence reactions. A PCR technique has been developed to detect characteristic DNA sites. Prognosis and prevention. The prognosis is doubtful. Mortality rates reach 97%, but improving diagnostic methods and developing new treatment regimens increase the likelihood of a successful outcome. There is no specific prevention. Non-specific preventive measures include compliance with the rules of personal hygiene, prohibition of bathing in infected reservoirs, especially in hot weather, refusal to use questionable liquids for rinsing the nasal cavity. It is necessary to carry out sanitary control of water quality, carry out work on its purification and prevention of infection, observe the temperature and hygienic regime in swimming pools. Treatment of non-gliriosis. Treatment is carried out in a hospital in the intensive care unit. Specific drugs have not been developed. Positive results have been noted with the use of amphotericin B, which is administered intravenously, subarachnoid, or into the ventricles of the brain. In experiments, a positive effect was observed from the combined use of amphotericin B and azithromycin. A scheme of fluconazole plus amphotericin B plus rifampicin is being developed. In parallel, symptomatic treatment is prescribed. According to indications, detoxification, dehydration therapy is carried out, means for relieving seizures, antipyretic analgesics, glucocorticosteroids are used, artificial ventilation of the lungs is carried out. In the American city of Tayheim, California, a boy died after swimming in a local lake due to a brain-eating amoeba. The shocking case was reported by the Associated Press. Fowler's unicellular non-gliria entered the human body through the nose. He was taken to a medical facility in serious condition, but the boy could not be saved. He died just a few days later.